This 81-year-old woman was admitted to hospital with a history of vomiting and diarrhea. Her abdomen was found to be tender and peritonitis was diagnosed. Unfortunately, she rapidly deteriorated and next day died. A post-mortem examination was performed. Here we see the abdomen being opened. When we incise the peritoneum, a lot of yellow fluid pours out, in this case over 2 litres. It looks yellow because it contains fibrin, which is yellow, and pus, which contains white blood cells. It smells absolutely disgusting. Purulent serous fluid in the peritoneal cavity is a sign of acute inflammation involving the peritoneum. The serosal surface of the bowel is red. The bowel loops are stuck together. The patient has acute peritonitis. The bowel loops are stuck together by fibrin, which is the yellow strandy material we see here. The fibrin is part of the acute inflammatory exudate. Here we see the cause of the peritonitis. Part of the small bowel is black. This is a bowel infarct, a zone of necrosis due to obstruction of the superior mesenteric artery. Blood has seeped into the necrotic bowel, giving it a hemorrhagic appearance. It is a hemorrhagic infarct. The necrotic bowel sets up an inflammatory reaction which spreads to the entire peritoneum, causing peritonitis, which has killed the patient. Because of the amount of yellow fibrin on the serosa, this may be termed acute fibrinous peritonitis. But if there is much pus, the term suppurative may be applied. Here's a cross-section through the black piece of small bowel. We can just pick out villi. But the nuclei of the cells have disappeared. The tissue is necrotic. Throughout the bowel wall, we find neutrophil polymorphs, each with its typical lobed nucleus. They are part of the acute inflammatory reaction to the infarcted bowel. There are also red blood cells, indicating hemorrhage, which is why the infarct appears black. The peritoneum thus shows an acute inflammatory infiltrate, with pink staining fibrin. This is the fibrinous peritonitis we saw before. The cause of death in this case is therefore acute fibrinous peritonitis due to small bowel infarction. This woman of 78 was found at home lying on the floor. She was found to be hypothermic and was admitted to hospital, but died soon afterwards. When we open the bronchi, we find pus in the lumen. There is suppuration. In other areas less severely affected, Beads of yellow pus can be squeezed from small bronchi, and the lung feels firm. It is said to be consolidated. This is typical of bronchopneumonia. When we slice the lung, yellow pus oozes from the alveoli and bronchi onto the cut surface and knife. This is acute suppurative bronchopneumonia and is due to bacterial infection. Microscopically, we see that the alveoli are full of pink-staining fibrin and neutrophil polymorphs. The polymorphs are trying to phagocytose bacteria. This elderly woman has thus developed bronchopneumonia at home, fell on the floor, where she became hypothermic, and finally died of the bronchopneumonia. Pneumonia has two main appearances. This is a normal chest X-ray. The lungs appear black because they are full of air and do not obstruct the X-rays. In this case, there are lots of white patches over both lungs, especially in the lower parts. The inflammatory exudate obstructs the X-rays and looks white. Bronchopneumonia is patchy because the inflammation starts in the bronchi and spreads outwards into the lung parenchyma. This X-ray shows a second pattern of pneumonia. Only the right lung is white. On the lateral X-ray, we see that only the lower lobe is white. The edge is clearly demarcated. This pattern is called lobar pneumonia. In lobar pneumonia, the inflammation spreads through the alveoli of one lobe. Lobar pneumonia is much less common than bronchopneumonia. This elderly woman was found collapsed at home. She was markedly hypothermic and had a rigid abdomen. She was admitted to hospital but died. The body has been opened. In the left side of the abdomen is a mass. It contains yellow, watery pus. It's an abscess in the retroperitoneal space. By squeezing the left kidney, we can express yellow, creamy pus. The right kidney is normal, but the left kidney is enlarged. It is difficult to cut. It contains more pus. This brown object is a stone in the renal pelvis. Pus in the renal pelvis is called pyonephrosis. Here we see a hole through which the infection has burst into the retroperitoneal space to form the abscess we saw at the beginning. Microscopically, here is a glomerulus. The cells infiltrating the surrounding kidney are neutrophil polymorphs. Inflammation of the kidney is called pyelonephritis. In this area, the renal parenchyma has been destroyed, with formation of an abscess full of polymorphs. The patient has therefore died from widespread intra-abdominal infection, the retroperitoneal abscess being due to rupture of the renal abscess. This was due in turn to infection in the renal pelvis because the urine outflow was blocked by a stone. This elderly man was admitted to hospital with trouble passing urine and pain when he did manage to pass it. In hospital, he unfortunately died before he could be treated. Here is the bladder and prostate. The prostate is hypertrophied. The bladder mucosa is red due to congestion and bears a yellow exudate of fibrin. Inflammation of the bladder is cystitis. Congestion and hemorrhage are often prominent, so it is often called acute hemorrhagic cystitis. Thus, the patient has acute cystitis because the hypertrophied prostate obstructed the flow of urine, which then became infected. He became breathless and cyanosed, and when he was admitted to hospital, a chest X-ray showed what appeared to be an abscess in the left chest wall. At post-mortem, the rib cage has been sawn free. When it is removed, we can see a large pool of yellow pus in the left pleural cavity. Pus in a serous cavity is called empyema. In the trachea and bronchi, we see more pus. The patient has bronchopneumonia. Notice the pale areas of suppuration, such as here. The patient has died from empyema, that is, pus in the pleural cavity, which resulted from spread of infection from bronchopneumonia, which in turn followed inflammation of the trachea and bronchi due to chronic bronchitis.